This audio lecture is the lecture for chronic illness, disability, or end-of-life care for the child and family. What we're first going to talk about is the child with special needs and the family, how they interact with the child with special needs as well as their needs, and then we'll talk about end-of-life care. So when we talk about the child with special needs, we need to go back to the beginning of what we talked about at the start of the semester about family-centered care. So obviously our goal in caring for the family is to support that family and help them with coping mechanisms, help them to promote the optimal functioning of the child, as well as the normalization of their own lives. So when we talk about trends in care for children with special needs, we have to think about focusing on optimizing their development. So we need to really focus as care providers as focusing on their abilities rather than their disabilities and helping potentiate their outcomes. We need to also provide the child as well as the family with coping skills so that we're able to maximize their developmental level and their outcome. When we talk about family-centered care, we talk about the family healthcare provider communication and that open communication to facilitate decision-making and continuity of care. We have to help families because this is an extremely frustrating time. Parents and children with special needs get extremely frustrated with the system. They meet many obstacles. Things become extremely difficult, and they need to know how to navigate the system. They also get frustrated with us, even when we're trying to do our best. They don't always understand that we're doing the best within our limits. So we need to make sure that we allow them to vent and verbalize those frustrations and provide them an outlet and resources so they can pursue and get done what they need to get done for the best betterment of the child. We need to make sure we're establishing therapeutic relationships with those families. I will tell you it'll go a long way if you know the family and you could talk to them openly, you know what's happening beyond just that child. If you get to know the family, it helps the family understand you and it helps them have a better understanding of how to get things done, and they're more open in expressing their frustrations as well as the needs that they have so that you can help them. The other thing when we talk about family-centered care is that shared decision-making, that we're going to help facilitate decision-making for families, we're going to help optimize outcome, that we're a team, we're going to work together. We're not going to make decisions for them, but we're going to help them with shared decision-making. Another optimum thing is when we look at children with special needs is really looking at the normalization of these children and their socialization. We want to make sure that they're attending school. We want to make sure they can get the bus and they get the facilities they need, the resources they need. Maybe they need physical therapy or occupational therapy. They may need an IEP, an individualized education plan at school. They may need to be in a self-contained classroom. They may need a nurse. They may need to go to the nurse periodically for medications or gastrostomy tube feedings. But we need to make sure that we're educating them to the best of our ability, in addition to providing that socialization. If there's a hobby that they can take place in, if they can join a club or a community program. The other thing is we need to think about normalizing them and socializing them because eventually these children may be adults. And advancing into adulthood, we have to think about, have we educated them? Are they employable? Can they live independently? And we need to optimize their education and training early so that we're sure that we potentiate their outcome. So when we look at the impact of a child with chronic illness or disability, we often talk about the child and how it affects them. And we've talked about that most of the semester. Now, what I really want you to think differently about now is how that child affects the family. So not just that child and being hospitalized and missing school and the potential for growth and nutritional problems and all the things related to their disease. I want you to think about how this child with chronic illness affects the parents and affects the siblings within that family. So obviously there are certain milestones that parents become extremely stressed with regard. The first thing is grieving the loss of a perfect child. So if you have a child who is born with a congenital problem or a genetic defect, that may happen prenatally, it may happen postnatally after birth, it may happen at the time of diagnosis, perhaps a child with autism who's finally diagnosed at 2 or 3 and is given the name of autism. Parents will grieve the loss of that child. And at that time of diagnosis is a really, really high parental stress point. So even though you're providing information, they may not be receiving that information or comprehending that information. If it's something where the parents feel responsible, if it's a congenital defect, if it's a genetic defect, if it's autosomal recessive, they realize they've actually passed on that genetic defect to that child, they may feel inadequate. They may feel like a failure. They may feel guilty that they've caused this particular problem in their child. The other thing we forget about with parents is the financial and emotional burdens of caring for a child with disabilities. This is not inexpensive. Many children have insurance because they qualify for state programs even if the parents are indigent or maybe above that qualification. You know, children are required to have health insurance, and there are resources through the state to ensure that. But many of these services go beyond what health insurance covers. There are still co-pays and deductibles, and there are still things outside the healthcare system that need to be provided. Maybe physical therapy is offered once a week, maybe the child would benefit for 2 or 3 times a week. That may not be insurance benefit, so the parents have to scrounge into their pocketbooks and find those funds. In addition, it's extremely emotional and it's extremely time consuming, and we get care provider burnout. We need to make sure that we're thinking about respite care for families who are really providing 24/7 care for these children, and make sure that they're getting some support with care. When we talk about how parents fit within the system, many marriages end up in divorce when there's a child with a chronic illness or a disability. We have parental strain, we have family strain. We have to understand, if we're going into a home and providing home care, how the parents may differ. How do they approach the illness? How do they interact with the child? How do they cope? And we talk about single parent families where there's one person caring for that child, as well as perhaps other children within the family, and the burden and responsibility that falls on one care provider and the stress that that elicits. We find that parents also tend to overprotect children with disabilities and chronic illness. They want to protect them because they're concerned if they have asthma, they don't want them to get a viral illness and end up hospitalized again. Or if they have a child with cancer and they are on chemotherapeutic drugs and they know they're immunosuppressed, they're very concerned about making sure that they don't get an infection from another child. So they may not want them to be socialized or be in activities with a lot of children or go to the playroom while they're hospitalized. So parents tend to overprotect them. We as care providers need to try and balance that a little bit. We have to remember that children really need to play, and we need to make sure that they're getting that socialization and stimulation and they're with their peers, because that's part of their growth and development. So we need to find that balance for parents. So when we talk about those stress points for parents, we talked about that time of diagnosis. It may be, that time of diagnosis may be when a child with a toddler runs in front of a car and ends up with a traumatic brain injury, and the loss of that child is later. It's not in the newborn period or in toddlerhood. It might be at 4 or 5 when they're hit by a car and they realize that child's life has changed and their life has changed. We notice that there's an increased stress during a time when a child fails to meet a particular developmental milestone. So if you have a child who's lagging behind, there's a little bit of give for a certain period of time, and then as parents watch the other kids at the school bus just do certain things, or the other kids in daycare or their nieces and nephews do certain things, and they realize their child is lagging behind, that's another wake-up call for them and becomes stressful. We notice that when kids enter school and they're not keeping up with their peers and they realize they may need to stay back and not progress to first grade or not progress to second grade, that again is a high stress point for parents. And when during that education or even motor skill, we have a child who plateaus and they realize this is really the best motor activity they're going to have. This is the best they're going to be, at least for this period of time until technology advances and maybe new things will come in the future. Adolescence is another really high stress point for parents. Remember, these children are fertile. They have sexual desires. They're going to become sexually active. They realize when they become fertile and they start to mature that these children may not have families of their own or may not have those opportunities to have a family as they have. You know, it really depends on the disability. And we talked in one of the first lectures about what someone views as a disability may be very different from what someone else views as a disability. So you need to weigh that when you interact with families. Some people see a very mild disability as life-shattering, and some families will see a major disability as a minor inconvenience. Another major stress point is thinking about future placement for a child. And I mean that in the respect that many families will care for children as long as they possibly can at home, but sometimes they get to a point where they're unable to, whether they don't have the physical means, they don't have the financial means. We have people who become too big, too burdensome, they don't have enough help at home, they can't get home care to assist them, they can't move them in bed, they can't bathe them, they can't get them mobile, that placement really becomes the only option for them. And that's stressful, especially for a family who really wants to care for that person at home but doesn't have the resources available to do so. And then if you have someone with a chronic illness where we realize that there is going to be impending death or imminent death, planning for that death is another parental stress point. So when we talk about those stress points, it isn't that a family doesn't understand the diagnosis and they don't know what's coming their way, or that they don't understand that their child with Down syndrome may have slower developmental milestones or not meet developmental milestones or academic milestones. It isn't really necessarily that they're in denial. It's that it's a wake-up call. It's another thing that slaps them in the face to remind them, my kid is not like all the other kids. So it isn't necessarily we need to provide reinforcement and education, but it isn't that they don't understand or they don't get it. It's just another reminder. They have a meltdown, we support them, and they come back to where they are and they progress. The parents are extremely strong, extremely resilient, more so than I think most of us could ever imagine. When we talk about siblings, they also are in the fire for all this. We realize that a lot of siblings have increased depression or anxiety related to this chronic illness. They're treated differently than their sick sibling. Frequently, they're disciplined differently. They're held to a higher standard or a stricter standard than their sick sibling. So they may feel that they're getting the short end of the stick. They may be assuming responsibility for caregiving that may be welcome or unwelcome. They may notice that there is that inequality in the relationships. They also have opportunities that are missed. Parents may be missing soccer games or ballet lessons, or maybe the family can't afford those ballet lessons because there are financial restraints that they don't have those resources available. They may miss holiday celebrations because a child is hospitalized or receiving treatment. The other thing is, depending on the developmental age of the child, they have mixed feelings. So the younger children may feel that whatever this child has, their sibling, they might catch it. So if it's something like cancer, where the child is not going to get cancer, it's really important for us to make sure we're educating them so they understand that they're not going to catch it. They also may have some thoughts of magical thinking where they feel that because they wished something ill on that child, they caused it to happen. And they also can become very angry and act out against that child or in response to their parents. So when we talk about the impact of chronic illness and disability on a child, we have to, of course, go back to Erickson. That's the picture of the guy on the slide in case you wonder what he looked like. But we have to think about development and really understanding that disability, working on focusing on abilities, not disabilities, to promote normal development, and making sure we're supporting them appropriately so that we can optimize their potential. So whether that's physical therapy, occupational therapy, a walker, AFOs, those orthotic foot, ankle orthotic foot devices to get people up and walking, whatever that may be, to help get them developmentally stimulated, treat them on their developmental level, and optimize their function. When we talk about coping mechanisms for the child with special needs, we have to think about their adaptability and optimizing that as we talked about their development. We need to have realistic, futuristic goals for self-care, independence, education with, as I said, realistic, futuristic, hopeful, but realistic. So we need to make sure that we're optimizing their potential and we're making use of and giving them the resources that they need in order to do so. When we talk about parental responses to chronic illness and disability, we talked a little bit about discipline. We talked about this in the earlier lectures, but we have to remember, children with disabilities need discipline just like every other child. They can't run around willy-nilly without discipline. So remember, we need to discuss that with parents, allow them to understand that discipline is still needed. It may be a little bit different than their children who don't have a disability. It might need to be of shorter duration because their intellectual ability may be different, whatever that may be, but children with disabilities and special needs need discipline the same as a child who doesn't have that disability. Children are children. The other thing is, when we approach a family with a child with special needs, it really is fascinating to watch what we call a disability, what we call an illness, and how those families cope. And what is well known in the literature is the better the family copes, the better the child copes. So how that family copes and views that disability or that illness is likely how that child is going to cope and view that quote-unquote disability or illness for themselves. Now we're going to talk a little bit about end-of-life care. And I think that end-of-life care is always challenging, and it's especially challenging when we talk about it with respect to children. It seems like something we shouldn't have to talk about, but unfortunately there are children who have chronic disorders, and end-of-life care is part of our care. I think that one of the things we forget about with end-of-life care is that palliative care is treatment and it is care. And I think that when we talk about withdrawal support and palliative care, we think of it as being so futile. And I think we don't value the importance of it and really realize how supportive it can be and how focusing on that support rather than a cure and really providing that emotional and comfort care to a patient and their family is really valuable and is treatment and is care. When we look at the WHO, they do have a definition of palliative care, but I really liked the end of it that I put on this slide. The goal of palliative care is the achievement of the best possible quality of life for patients and their families. So again, it really is optimizing the best of a bad situation. Continuing on, we talk a lot about decision making at end of life. So obviously there are a lot of ethical considerations that we have to think about at end of life decision making. How far do we go? How aggressive are we going to be? And in children, we tend to be more aggressive because we think of children as being at the beginning of their lives. So you think of Grandma Bessie, who you might not think about putting a tracheostomy and a G-tube in. You think differently when you realize it's a 6-month-old or a 10-month-old. So thinking about ethical decision making and coming to grips with your particular views your beliefs and understanding that those beliefs are not necessarily the beliefs of those families and those children that you're caring for. This is really a lifelong thing. It's a career goal. It's something that takes time to figure out how to deal with conflicts of ethical decision making and considerations in end-of-life care, and how to best actually treat families and provide them with the best care. We talk about euthanasia, and euthanasia is obviously not something we can do. We are not going to, euthanize people in healthcare at this time, as certainly not in the state of New Jersey at this time. But I think that understanding within the Nurse Practice Act, within your role as a nurse, your obligation to provide comfort care, and what is truly euthanasia versus what appears to be a very high morphine dose in someone who is very tolerant to morphine, are two different things. And I think it's really important for you to occasionally look at those guidelines and realize that providing that comfort care is part of your responsibility, and providing morphine or another analgesic at the end of life is not euthanizing someone. The other thing we really have to think about is how we're going to provide accurate, open, and honest communication and information for families at end of life and the children. And there are situations where parents don't want their children to be told about their diagnosis or don't want them to know. And I will tell you from my experience, most children know maybe before the parents know. They know they don't feel right, they know what's going on, and they hear everything. So although the parents may think that the child doesn't know, chances are they do. It is your responsibility to respect their wishes, but if a child discloses that information, or you can understand that they do understand that information, you may help ease some of that stress of the parents trying to withhold that information from the child. When we talk about parent decision making, we really have to depend on, they really do depend on us being honest. There are times when they will want to be in the driver's seat and make all the decisions, and there are times when they may want a little more of a paternalistic approach, and they may ask the healthcare providers, what do you recommend? What is your advice? I'll do whatever you tell me to do. So, and you may notice families vacillate between those two things during those stressful times. And if you realize end of life is imminent, you really need to explore what the parents want. How do they want the child cared for? What are their expectations? How can you make that a much more pleasant pleasant encounter for something that obviously is not something that is something anyone would welcome? We have to really have good physician healthcare team decision making. We need to make sure that that involvement is good between the families, that there's consistent and open communication with the families, and we understand the options for DNR, what those entail, make sure the orders are up to date if they want it, and understand that even if a family says they don't want anything, they might change their mind, they may vacillate. Or if they have wanted everything done for a long period of time, they may wake up one day and say, you know what, we're done. And that they know that they have that option to change their mind. So when we talk about developmental aspects, we also are talking about ways that different age group children will respond to death, whether they are the patient or whether they are the sibling related to that child. So if we talk about infants and toddlers, obviously for infants, there's little significant if you're less than 6 months of age. You want to provide comfort care if it's the patient who is expiring, but if it is the older sibling of a 6-month-old, they're not even going to have recollection of that child. I will tell you, for toddlers, they are extremely egocentric, and they are more disrupted by the disturbance in their routines than they really are about the loss. They don't understand the permanence or what's happening. When we talk about preschoolers, same thing. We have preschoolers who believe they may have caused death. They have that magical thinking. They may have, because they have wished ill on someone, they may think that they caused this illness or this problem, and they really do see death as something temporary. It's a departure or a sleep. They're away or on vacation. They don't understand that it's permanent. As we get into school-age children, again, they still feel that they may have caused death by some sort of misdeed that they engaged in or bad thoughts. They may feel guilty. They also may feel that there may be punishment associated with deaths. They're dying because they did something wrong. And interestingly enough, children as young as about 9 or 10 developmentally have an adult concept of death and understand the permanence of death and what it entails. Now, when we get into adolescence, although they have a mature concept of death and an adult concept of death, they may straddle between childhood and adulthood. So remember, during times of stress, children, even adolescents, are going to regress. And you may notice that at one time they're very mature, and in the next breath they seem immature and will straddle that maturity level. Generally, however, adolescents do have a mature understanding of death. So when we talk about death and treatment options for death and how we're going to care for children, there are several different options. Hospital care really isn't routinely used for children, generally because many children with chronic illness are plugged into a system and they have access to home care, long-term care, or some sort of hospice. Most of the children who die in hospitals are children who have had a tragic event. It may be a trauma patient. It may be a child in an emergency room from a car accident. It isn't necessarily a situation where a child is brought to the hospital to die. Most of the care in pediatrics really are at home with very good resources, whether that's 24-hour nursing, 12-hour nursing, 16-hour nursing, 8-hour nursing, a home health aide, whatever it may be, so that you can keep the child in the home, or really at end-of-life care, whether that's hospice within the home or a hospice within a long-term care facility. So when we talk about how we're going to care for the family and the child at end of life, there are a lot of things that families and children are dealing with. First of all, they're fearing the pain and suffering associated with death, and they want to make sure they're going to be comfortable. They want to make sure there isn't pain, and they want to know that there's going to be adequate pain management and symptom management. One of the things that often comes up from a parent perspective is the fear of addiction and the fear of giving their child medication because they're going to be snowed, they're not going to be aware, they're not going to know that they're visiting, or they're afraid that they're going to become addicted. At end of life, addiction is the least of their concerns. Comfort is the priority. And if they're a little snowy, they're a little snowy. It's okay. I think that, addiction in children is very rare as it is, but certainly at end of life, it's not something that needs to be something, we don't need to hold back on pain management because we're concerned that a child who's dying is going to become addicted. And I think that is a teaching point for parents, to make them understand that and understand that adequate pain management is really, really key. The other thing we need to do is make sure that we're adequately, educating parents and siblings so that they understand those fears and what pain is and suffering and how to optimize and provide really good comfort care for their loved one. Another fear that happens is that fear of leaving a family member and that they will die alone. Their child will die alone. Their brother or sister will die alone. So there is unlimited access in a healthcare setting if someone is at end of life. So whether that's a long-term care facility, whether that's at home through hospice, whether that's in a hospital and you realize death is impending. They usually have they send all the rules out the window and there's unlimited access so that there's always someone who can be by the side. The other thing is you will find out that you as a nurse may pitch in for the family so someone can go home and take a shower or get a cup of coffee or whatever it is, so that if there isn't someone who can be with that loved one, you can be there so that they know that should something happen, their child will not be alone. The other thing is it's really, really important for families and children to understand what will happen and what to expect when someone is dying. So understanding the involvement, that really good education, that hospice support, anticipation of what's going to happen in that education is incredibly wonderful. And the other thing to think about is when you have that fear of actual death and that education, a hospital death when there isn't a lot of preparation is very very different than a family who has had adequate preparation and they know that this is impending. So how you approach that family and how you interact with them will be very different if it's a tragic loss versus something that's chronic and has been well prepared for. So at end of life, there is an obligation to contact the donor programs to see if anyone who is ready to expire or has expired is a good candidate for transplantation. And healthy children who die unexpectedly actually are excellent donors, and there are many, many people waiting for organ donation throughout the country. So ideally, we would like to discuss this with the family before death, if it's someone who we know has impending death, someone who's been in a car accident where they're considering withdrawing support or something like that. We would want to meet with them before that time. And often, although in some institution it's done by the healthcare providers in the institution, frequently they're shying away from that and actually using people from the donor programs. So the New Jersey Sharing Network, they have someone who's contacted from that program who comes and speaks with the family. I think what they've found is a lot of people are nervous that if the physician is saying, hey, we'd really like your kidney, they're going to withdraw support faster than if it's someone who's removed from the situation and they think that it's a little bit more better received by families. And we really need to understand that there are a lot of things that can be donated, not just hearts and kidneys, that may be able to be donated after death as well. So we need to make sure that families are aware of that option, and often families are receptive to this because they realize although they're going to lose their child, their child could perhaps go on living through the life of prolonging and restoring the life of another person. So within the state of New Jersey, it is mandated that I contact the organ donor centers so that they can determine if the person who has died or is going to die is considered a donor and meet with the family. So when we talk about grief and mourning, I think that sometimes we forget that there actually can be physical grief, that everyone goes through denial and bargaining and depression and acceptance and anger, just like Kubler-Ross talked about many years ago. And we're all going to go through that vacillation. We as care providers will go through that vacillation with people who we've cared for a long period of time, or even just being in the presence of a family who is grieving. But we need to know when that grief goes beyond. And you will find that when you're taking care of people with chronic disability and you get to end of life, that you know these families and you stay in touch with them and you reach out to them after the loss of their loved one. So you need to think about that immediate somatic distress, that those real physical feelings of that empty, that feeling, that pit in your stomach, weakness, headaches, being distracted, unable to concentrate and focus, that tightness in your chest or shortness of breath that people can get. Those are really physical things that can happen. In addition, a preoccupation with the deceased for a long period of time beyond what would be considered reasonable, those feelings of guilt or hostility, that anger that comes, as well as losing normal patterns of conduct. So someone who turns to alcohol, someone who doesn't take care of their physical appearance, they're not showering, they seem disheveled, they're not attending work, that you actually can have normal symptoms and then you can have symptoms that go beyond. So we need to recognize these as normal for a brief period of time and then recognize and help families if they extend for a longer period of time. So ultimately our goal is to support grieving families, support the children, support the families, support the siblings, support the grandparents in extended care, partners, whomever is involved. And remember to take care of ourselves as well in the process, because this is stressful for everyone on all fronts, and we really need to make sure that we're caring for everyone in a holistic way.